So thank you to our morning presenters, and Karen, thank you very much for an excellent presentation. Um, that was terrific. We kind of quickly went to break and didn't get a chance to say thank you, but wonderful job, thank you. And to Ben as well. Excuse me. It's a privilege now to present this afternoon's speakers. So we're going to be introducing Angela Roberts. Angela Roberts is an assistant professor of communication sciences and disorders in the School of Communications at Northwestern University, who's also faculty affiliated in the Cognitive Neuroscience Program and Linguistics Department at the Meslem Center for Alzheimer's Disease and Cognitive Neurology, and is also an adjunct research faculty appointment at the Western University in London, Ontario. Angela is a proud graduate of our Scholars Program from the early Andri and has sort of grown into a all-star faculty role and is actually now on the Andri executive. Her translational research program develops novel speech and language biomarkers for diagnosing neurodegenerative diseases and for monitoring progression of cognitive impairments and disease symptoms. She'll also be speaking with Dr. McElroy. Bill McElroy is a standout researcher who has been leading the AIM2 platform in Andri. He was the lead of the Gait and Balance program platform in the original Andri study and is leading a lot of the work that you heard Karen and Ben speak about today, along with Karen. Leading AIM2, as we mentioned, and is one of the, together, Angela and Bill are both serving on the executive and are helping to lead us in the development of the Hands Ontario program and platform. So welcome to both of you, and thank you for joining us this morning.
Slide into some slides in a minute, but we're going to give you a little bit of an education on the devices we have been using and the devices we plan to use. And I'll go across this table to give you a sense of what they are. All of these devices I have in front of you are either devices that we have used in the REMIND study or devices that we're planning to use into the Hands Ontario study. And if I just, the quarter is a reference. By the way, it's surprisingly difficult these days to find quarters. This took me a good couple of hours running around the house. I guess we just don't have a lot of change. So the very first thing I wanted to show you is this device right here. This device is one of the first devices we used in the first studies. It's a gene active accelerometer. The interesting part of this one is sort of the research gold standard from some time. It's a wrist-worn device. It's literally worn as a wristwatch. We adapted this device also to be worn at the ankle, and we've developed what we consider fairly comfortable strapping system in order to apply these in different body parts separate from a wristwatch. These devices are worn 24/7. They're worn, if people are willing, wear them all the time. The interesting part of these watches is there's no face panel. It's not really a watch. It really is just a data collection device with accelerometry. We use these in REMIND. And in REMIND, we also use this ECG monitor. This is a very tiny monitor that measured ECG and had some acceleration. The challenge in this device, and I think people who were in the REMIND study would certainly reflect, this is the contact. This would have gone on the chest and this tucked into it. That would have been the set along with an ADAM sensor, which we're going to have Angela talk about with respect to the ANIs in a sec. So I'm going to take those off the table because what we learned from those are a bunch of things. A lot of them came from our participants. And one of the things the participants talked a fair bit about is a smaller footprint. Fortunately, an Axivity device has come on the market recently. This device here is our newer version of the accelerometry, again, a research grade device. As you can see, it's quite small, smaller than the Gene Active comparison. It also tucks into a wristwatch version. I'm wearing it now. I'm wearing the devices today. And this device is interesting because it has acceleration and gyroscopes in them. So we get a lot more information off this device in terms of motions from ankle and leg. One of the things that's happened over the time, though, is continuing advances in sort of physiological monitoring and speech monitoring. And one of the devices, in partnership with a company that Ange is connected to and that the Andri is importantly connected to, involves this sensor. And these sensors are referred to as ANIs. I'll just give you a quick little show about their size and their features. These are flexible devices. This particular device would be mounted on the chest with adhesive up near your sternum, up near your throat. And the other part that comes along with it is a finger sensor, and it has a little sensor in the end of it, in which case it gets wrapped around your finger to measure oxygenation. Now, anybody in the Remind study who was in the Remind study would have seen a version like this. This is also an oximeter that's used. These are a little bulkier, kind of get in your way. They can be worn overnight. This version now, this new technology allows this to be done not just at night and sleep, but also could be worn during the day. These ANI sensors are both physiological monitoring with respect to their ability to capture ECG, ventilation, and that sort of stuff. But importantly, they're also capable of measuring speech. Now, Ange is the expert in this space. So I'm going to pass Ange. I have some slides too. I don't know if you want to talk a little bit about how you might use these and how you and the value that they provide to us in terms of a tool to complement accelerometers.
Sure. Are you guys able to hear me? Bill, can you just give me a thumbs up? Okay, perfect. Or a finger wave.
There we go. Thumb up right there.
So Bill and I have some slides that we'll talk about in, some of the functionality of these devices here in a little bit. But I think briefly, one of the reasons that we actually even moved toward trying to design a device similar to the ANI device that you see in front of you and the electronics that are kind of encapsulated in that shell was that as a communication sciences and disorders person, we had all of this great wearable tech for measuring kind of movement and falls, but we had no real way of measuring people's social interaction or their speech patterns outside of the clinic. And this was really frustrating. So we had, if I was working with someone's speech or trying to improve communication between they and their family members, in the clinic, I could see all of that, but had no idea what was going on outside of the clinic unless we outfitted their whole house with speakers, microphones, and video cameras, which was rather intrusive. So about 3 years ago, we set about working with these engineering partners to develop a technology and a device that we could send outside of the home with people. And the great thing about this is it had the added kind of ability to collect all kinds of other behaviors, such as gait and walking and movement. We now are validating measures to use it in the case of swallowing, so we can measure swallowing counts, and we can look at how the breathing system is interacting with the swallowing system to look at the quality of swallowing and also the risk of aspiration. And in some new versions that we're working toward, we've actually built in haptic feedback, so we're able to use this in a treatment context to provide feedback to people. So we're really excited around how technologies like these and others that I'm sure will be coming out in the future pushes beyond looking at people's worlds, beyond just kind of gait and movement, and allow us to look at interactions between speaking, communicating, and moving, which really for the first time only in the last couple of years are we able to do. So I think this allows Bill's world and mobility and my world in speech and communication to come together in some single small devices that people can wear that are comfortable and minimally obtrusive. So Bill, I'll pass it back to you.
Thanks, Ange. We, of course, the benefit of the ANIs, we get that additional physiological monitoring, which is important to complement all of this, including our ECG, our cardiovascular measures. The Ange's point about wearability has been critical to this. So I had mentioned before, the wrist-worn ones are often as a watch, although sometimes the watch, people replace it with our strapping, which is a sort of a comfortable elastic strap, which either one's usable. I have one, I'm not sure I can do this. I don't have the flexibility to get my ankle up on the counter there, but I have one on my ankle right now. I'll just see if I can do this. Just let me, just you can see it's basically, let's see, I just got it here under my, this is just under here, a little strap under my ankle, just wraps around my ankle. And I wear that sort of all the time, 24/7. I take it off in this particular case when we have a shower or something like that. These aren't this particular one. While they have some waterproof capability, we've been in the habit of removing them. As the technology improves, we're going to, I think, be at a point where it will be possible. We're not bound to this particular technology at this particular point. Our partnership with Cybele is leading us more and more to the opportunity of having these be our go-to devices. For our purposes, the interesting part of it is all of these devices here that I've shown you, all of these feed the same data to us. Like it for us, it's less about the device and more about the data. The device provides us the convenience, the multinodal possibilities off a particular device, how it shares the data, but the core measures that we're trying to extract are device, in our minds, somewhat device independent. So we're opportunistic when it comes to tools. We just happen to have a wonderful partner here in Cybele with a very interesting technology that I think will help advance this considerably.
Yeah,
so
Bill, and I think, so I'll just point out, I think what helps is the placement of the Cybele devices, right? So, you know, our ankle-worn devices don't give us any information about speech or swallowing. And so the placement, it's part hardware, but also part placement. And that's what we've also been exploring, right? Is a kind of optimal placements for some of these devices to get maximum data yield with as few devices as possible.
Yeah, and to Karen's talk before, and to your point there, Ange, our set now, our suite now that we're comfortable with in most cases is the chest worn one that just adheres on. It's an adhesive that sticks to the chest, easy to mount. There's basically an adhesive that goes on the back of this device. That adhesive then gets placed onto a location, folks. It's relatively easy to put on when you're sort of trained how to do it. And you literally just wear it. You're not monitoring, you're not have to do anything with it. The same with these devices. You put on the wristwatch, you put on the ankle strap. But for us right now, it's chest for all the measures Ange just talked about, wrist for lots of different reasons, and ankle because gait is, particularly in certain populations of interest, such as Parkinson's and where we're interested in the quality of that walking, not just the volume, is really important for us. I will take the liberty maybe to switch to the slides briefly. I'm just going to share my screens and just show you, because had we been truly live, we would have had an opportunity to do this a little bit differently, but I'm going to just share some slides with you. Sort of addressed sort of what sensors we use, generally how they're worn. I'll tell you a little bit about what the signal looks like, at least from the accelerometry really quickly. Ben's done this and Karen's done this. And I just want to show you an example of some walking data. This is an IMU that's worn on the ankle. You'll see the one on the bottom trace and an IMU worn on the wrist. So these would be the inertial sensors I just showed you. The nice part about this sort of example data, it's a very typical walk with a typical arm swing. You can see a rhythm in the arms and you can sometimes capture that with some success. But when you're on the leg, the rhythm of gait is very clear. We can extract details of footfall information, step variability, swing time, stance time. The combination of wrist and ankles helps us when we're looking for instability and even falls. But the wrist itself, as you can see, is a less regular signal. And while it can be used for gait, it is problematic when you have groups that don't have large arm swings or walk very slowly. So this is to Ange's point, really important about where you wear these things. This one, I show this one only briefly just to show you the other thing that's really, I'm going to stop this right at the beginning. We're really interested at the very beginning in terms of gait initiation, for example, how people begin their walking. This is particularly important in people with sort of gait disorders. You can extract out the characteristics of how long it took them to get up to speed. The arm swing data is not as sensitive in that particular case, but we can extract information about how they walk, the details of that walking. Importantly, here is a good example of cycling. This is Beth Godkin, who will be speaking later, just showing the accelerometry. No surprise here. Accelerometry has a very different pattern. This is the nice part about accelerometers and understanding the characteristics of the waveforms. You can extract different behaviors. Of course, the arms in this particular case are not going to be, and not surprisingly, not that effective in characterizing activity. Adding heart rate to this is really the value of adding the ANI sensor and our ECG to get an intensity measure. And then this is the one that, oh, we'll just skip this one. This is the one that we all have fun with. This is Ben making a pizza. I show this one because it is also true that one has to be concerned. The legs are an interesting place to measure mobility and cycling because they're the patterns are very predictable in terms of making contact with the ground or devices, sort of reduced degrees of freedom. The upper arms don't have those restrictions, degrees of freedom, and the waveforms get really complicated, and extracting what they're doing from the upper limbs is awfully difficult to do. You can see in here, this activity of daily living is characterized by a number of waveforms. So the activity here is both interesting and complicated. So there are some challenges in trying to extract it. We're not trying to extract out the time when Ben made his pizza, but we are interested in characterizing the activities of daily living. And so we continue to look for ways to interpret that from the arm signal. In this particular case, of course, the leg is not an informer at all about the activities of daily living. I share this slide ever so briefly just to indicate that when we're summarizing this data, of course, we have the luxury with the research grade of looking down to the millisecond level. We aspire for years and months. That's what we all aspire for. We aspire for this eventually being something that is not just weeks and days, but at the present time, we're in weeks, days, hours, seconds, and milliseconds. That's the space in which we characterize these data. And we have the luxury of that by here, and this is data that was shown as an example by Karen. We're looking over a week and then days within a week. We can look at within days, within person, looking for patterns, and then importantly, dive into the milliseconds, which we haven't shown you, which would be if you were looking at aspirations or coughing or moments of speech. We're not now looking to collapse data all the time across days and weeks. We're looking to look in moments of time. This is an example from some gait data where we believe there was some freezing of gait and some shuffling of gait that was characterized with the ankle-worn accelerometers. So the important part about what we're trying to do is we're not simply trying to get you a summary of the number of steps over the week. That has some value and utility. We're trying to characterize those important movement and physiological and speech characteristics that inform about progression, the characteristics of someone's activity that could inform about health and care. This is just a little bit about where the ANI system is run. I've mentioned that already. This is a little bit about the various physiological signals you can extract that I won't go into this, but I just want to pull up some slides for Ange. And Ange, you can we talk, this is the complexity. The nice thing about this, I'd make this point on behalf of Ange. Putting this on is really easy. Fortunately, you don't have to worry about all that other stuff. Yeah. All the user has to worry about is sticking this on, and the device itself does all the rest. The nice part about this, and I showed you this before, these devices are flexible, so they're very comfortable to wear. Ange, did you want to speak at all?
Yeah, I'll take that. Thanks. So I want to take this opportunity, I think, to highlight and amplify a couple of things that Bill said before I jump into these slides. And then I want to respond to kind of Hugh's question earlier in the chat box. So, one of the questions that Hugh posed was around why this? Why not just do self-report? If I go to the physician's office, just tell them how my week has been. It gets to one of the points that Bill just made a minute ago, which is when we commonly report how our day has been or how our week has been, it's collapsing a whole lot of millisecond to millisecond events into one perceptual expression of my day's been good, my day's been bad, my on and off cycles are predictable, they're not predictable in the case of Parkinson's disease medication, or my loved one is having better conversations in the morning versus at night. But those are all kind of, we as humans don't have the capability of really analyzing ourselves in a microsecond by microsecond basis. And yet we know that that data is important. Thinking about not only how the system is responding very quickly in moments of change and stress, but also how the system is responding across all of those levels of function. So I'll give you an example from my world. If I'm interested in what is happening to people in moments of communication difficulty, so you're trying to communicate something to your family member, they're not understanding you, and you have this kind of large misunderstanding in the middle of a conversation, we actually have some awareness that that causes a physiologic response. So your heart rate might increase, you might get a bit more anxious, but currently we have no way of looking across those systems to understand the dynamic between how you respond physiologically in those moments of stress that are linked to communication challenges. And that's a really unmet need in our field, right? Because if I want to understand the relationship between difficulties communicating and the physiological system, then I need to have a measure for doing that. And what these types of sensor systems do for us are two things. To address Hugh's point, it allows us to look at a time scale that we as human observers are not able to really extract information from, and that information is clinically meaningful. The second thing it does is it allows us to extract features that the human eye and the human perceptual system can't even see or process. So some of the data that I'm able to pull off sensors, and I'll talk about those in a minute, actually allows me to see things and hear things and perceive things that as a clinician, I can't do just with my own eyes and my own ears. And then the third is this incredible importance of looking at the dynamic response across systems. None of us operate as just walking beings or sleeping beings or heart rate beings or communicating beings. We are all doing all of those activities all the time and simultaneously. And so understanding the dynamic response across the system is incredibly important. And that's the real, I think, benefit to the approach that we're taking. And this new study is to say, gosh, we're not just going to look at your cognition or look at your genetics or look at your mobility. We're going to try to look across those systems in a time synchronized way to find out what's happening when you're both talking and walking at the same time. So I just wanted to take a minute to kind of circle back to some of those points and to close off a few questions that have been asked earlier. So to Bill's point, yes, you don't have to worry about the electronics other than to say it took a lot of really smart people, much smarter than I am, but who were willing to listen to clinicians on what the need was from our tools to be able to develop a sensor that works in this way. Bill, can you progress the next slide, please? Thank you. And this is a blow up of the figure that was on the previous slide. And I really, this complex figure is really just to make the point that this is kind of like adjusting a lens so that we can see different types of behaviors that come from the same signal in the same device, right? So if we're thinking about the single device that's worn at the chest or maybe even a device at the ankle or the wrist, it's important that we combine information from those sensors, but particularly from the one that we wear on the chest, we can actually extract a lot of behaviors just from that one placement. And the way we do that is in this background of the work that we've been doing in this kind of wearable sensor space. We're able to extract out, as Bill and Karen and Ben have all identified, signatures. So each one of these behaviors has a unique signature. And while it varies over time and varies in different conditions, the relative signature of that behavior stays somewhat the same. And what that allows us to do is kind of take a template and put it on the signal and pull out different behaviors. So what you see in this slide is on the far left, you have heart rate activity. And in the next block over, you have talking behaviors. And in the next block over, from these little kind of small squares with the blue lines, you have swallowing behavior. And then the next block over, you have walking behavior. So by using these kind of different lenses, we can adjust out and pull out different signals that let us look at each person as this kind of dynamically functioning person over time. And this is the real value in kind of this approach, along with integrating information from other sensors. Bill, can you progress the slide? So one of the novel ways that we've been trying to use this is to get an idea about how much social engagement or how much talking people do over a 24-hour time period. And this is important in my world because one of the things that we know happens in the context of neurodegenerative disorders and in the context of dementia is that people stop engaging as much. And yet we know this social engagement is really important from a cognitive perspective. So now what I'm able to do for the first time is pull out these 24-hour patterns. So what you see in the blue lines on this slide, and if you think about each one of these kind of time marks as an hour in the day, 1 to 24, what you see in the blue lines is one participant that was in our study, and this was an 81-year-old person who had a little bit of mild cognitive impairment. And then what you see in the orange bar is someone who had less cognitive impairment, so they were age normal, or what we call kind of age normal performance. And what you can see is both the difference in the height of the lines. So the orange bars are taller, meaning that person talked more overall in the day. And what you also see is a little bit more variability in those orange bars. So they talk a lot at some times and not so much at other times. And we can compare this to now someone who has more cognitive impairment to see what are their patterns in talking during the day, what are their peak moments of engaging with others. And now it lets us get a lens as to what's happening with people outside of the clinic environment, and also maybe when we can put in interventions. So if I can see that someone is really having very little social engagement during the day or social interaction, then what I'm able to do is help provide guidance to family members on optimal times a day when we may want to be engaging that person. Bill, next slide, please. And so then just briefly, and mindful of time, and I want to make sure that we leave ample time for Beth and Sonam here. This is just kind of some of the measures that we can extract out of the sensor. And I collaborate on this work with my colleague, Dr. Martin Harris, who's a world expert in dysphagia and swallowing disorders, who's also here at Northwestern. And she and I are co-inventors of some of the technologies that are used to measure speech and swallowing in these sensors. But some of the things that we're able to pull out are total talking time, the number of individual words that are spoken in a day. We're able to pull out measures of pitch variability. So that's kind of the tone and quality of your voice. And we're able to pull out information on relative loudness. So how loud are you? Day-to-day variability or within hour variability based on your own kind of typical loudness. We're able to pull out aspects of the strength of swallowing, which is important for swallowing quality and preventing aspiration, the number of times in a day that people swallow in response to saliva as well as food. And then, as I was saying a little bit ago, this kind of coordination of how you're breathing and how you're swallowing, which is super important therapeutically for we as speech language pathologists to manage, but also important from a risk of developing aspiration. So we are every day, the REMIND data currently actually are starting to get in the hands of colleagues of ours on the engineering side to extract out even more features in this space. But every day we're learning more and more about what these sensors can tell us. And Bill, you can progress on. And then I think I'm just going to slide over this slide for the sake of time, but it's to basically, the previous slide was basically to say, we know that increased social engagement, sorry, Bill, increased social engagement and lower levels of loneliness are related to better cognitive aging. They are a predictor of dementia development, so the less socialization or lower social connections you have is a predictor of dementia development, cognitive decline development. And we know that measuring things like talking time and some of that pitch variability and loudness variability are measures that we can use to pull out proxy measures of loneliness, social connectedness. And Bill, next. This is just a super quick slide, and again, not to rush, but the good stuff's yet to come, which is to say we've actually looked at developing, using the data that we draw off of these sensors, what we call a social engagement metric. And so this means that we can combine that information about talking time, words spoken in the day, loudness changes, pitch changes, and we can actually develop a measure that is a combined, or what we call a composite measure of all of those values from the sensor, to give us a single social index score or social engagement score. And we've validated that. So we've put it against kind of a validated pen and paper tool of social engagement, and it stands up pretty well in terms of it's pretty well correlated with that. And we think this is important for us being able to develop scores at both a daily level, an hourly level, and down to a minute level of people's quality and type of social engagement. One of the things I want to make clear about the sensor use, for those of you who may be concerned, there's actually not a microphone on it. So it's not actually recording what you're saying. We're not peering into your lives and taking out important information about your conversation. It's recording measures of speech that we can pull out using what's called a mechanoacoustic sensor. Same thing that Bill talks about, movement under the skin and airflow across the sensor gives us an idea about what's happening in the speech signal without us actually having to collect that data through a microphone. So we're able to analyze speech and analyze communication while preserving your privacy. And Bill, I will pass it back to you.
Great. I think we'll end there, except I need to thank Kyle Kyle didn't jump in and correct me. Doesn't mean I wasn't wrong on stuff. It just means Kyle will correct me later, I'm sure. But Kyle Weber, who's one of our important research coordinators, helped put all the slides and the videos together today. So I'd like to thank Kyle for doing that. And next time Kyle can do this presentation, good practice for him, right, Kyle? You don't have to
Sorry,
respond.
Kyle. I think I took over your
No,
spot, so I'm sorry.
No, you didn't. Kyle didn't have an aspiration to talk today, but maybe next time.